We're looking at a high school baseball player who complains of shoulder pain. Let's just say he's a pitcher who just started the season, maybe didn't do a lot of throwing in the off season, and now he's complaining 2, 3, 4 days into practice that he's got a lot of pain, just kind of right focused in the shoulder. He could have some radiating up to the upper trap, to the back of the shoulder, or down the front of his arm. But first, before I even look at him, I'm going to ask him questions about how much was he throwing prior to the season starting, and then what was the volume of pitching that he changed to, and what's he at now? Does it hurt at is it the actual releasing of the ball? Is it the late cocking phase? Anywhere in there? I'm just digging for any sort of information that I can. What's he doing on his own? Is he icing it? Is he resting it? Or is he just throwing through the pain? Is it getting worse? Is it getting better? All those kind of things. Once I kind of gather that, I'm thinking in my head just a hypothesis before I even look at him. But when we do go to look at him, the first thing I just want to see is his range of motion. What hurts, what doesn't hurt. So I'm going to have the patient keep his elbows straight with the thumb up, and I'm just going to have him straight ahead, just all the way up as far as he can in deflection. Then he's going to come down. He's going to go out into abduction. I want to see, I'm asking him here the whole time, what point of this motion hurts. Let's just say he's coming up and he says right in here. He starts to get some pain across the front of that shoulder. Yes, he can do the motion, but he has pain right in through here. Let it reassess it out into scaption. Yep, he really doesn't like that. He's got that full motion. If he pushes through the pain, I'm going to take him passively here. I always want to check what we call 90-90 external rotation range of motion, as well as internal range of motion. A lot of times in an overhand thrower, we're going to see a lot of external movement here and kind of a block there internally. With a thrower, I'm always going to check out the non-dominant hand just to see where he's at. More times than not, he's going to have a lot more internal mobility there, just telling me some things about the capsule and what's going on. So once we kind of figure that out, we assess his motion. Can you reach behind your back too? I'll see if that hurts or not. Might be a little bit tighter, uncomfortable here, might not. So that's just kind of our range of motion assessment. Then I'm going to go into some special testing. When he told me that he's got pain right in through here, we call that the painful arc. So my mind is already thinking probable shoulder impingement here. So I'm going to go ahead. The first thing I'm going to do though is just rule out his rotator cuff. So I'm going to assess that cuff with what we call an empty can test. So he's going to be in scaption, thumb down. I'm going to have him hold it there. I'm going to push. This really should not bother him too much. He might be weak, but he shouldn't have a lot of pain there. If he has pain here, now I'm thinking more rotator cuff. Then I'm going to rule out a labral tear. I'll bring you across. So this is called an O'Brien's test. You're going to hold thumb up. Don't let me push you down. He should be pretty strong there. Then he's going to release. He's going to go thumb down. He's going to hold here. Hopefully he's strong here as well. If he has some pain or issues here and he just drops with pain, now we're clued into maybe a possible labral tear. This particular patient, we're not picking up on any of that. So we're going to rule those two things out. Then we're going to look at our impingement test. So the first thing I'm going to do here is just a Hawkins-Kennedy. I'm going to rotate him down. And right there, he's going to say, ow.
Ow.
And I'm going to say, take your other hand and point to where the pain is. And he's going to point right to the front, right there. I'm going to come down. I might do a coracoid test just to kind of confirm some impingement. That's going to hurt as well. And he was already positive with what we call a Neer's impingement test, where he had pain right here just lifting. So just that little bit right there, I'm clued in that he probably has shoulder impingement. So that's the direction we're going to go. We always want to assess his strength in the cuff. So he's going to hold right here. I'm going to resist him internally to check that strength. More times than not, that's pretty strong. Then if we come to here, we come around, we're going to check external strength. Push out into me there. That one more times is going to be weak. He's going to have a hard time here. If I also, he's an overhand athlete, I want to check him here as well. Only push it down. Probably going to be weak there. I'm going to check internal, hold. They're usually pretty strong here. And he might even get some discomfort with one of these two assessments, or even down here on the external rotation. So let's just say he was weak through that cuff. We have the positive shoulder impingement test there. I might lay him on his back and check some joint mobility, given that he had the lack of internal rotation. But I like to head right into some strengthening and stability for him. So from a treatment standpoint, we're going to really work this rotator cuff. So we're going to come on over here. And you're going to go, depending on how much he hurts, we could go up the elevation, but usually I like to start him down low. I'm just going to go external rotations, then flip around internals if you want to show those. Wanting to know, is he hurting just doing this? Because if there is a little bit of bicep involvement, this might bother him. If that was the case, we would just cue it a little differently. I'm going to have him bring his arm a little bit more forward. I'm going to cue him to drop that shoulder blade down and back, hold here to here, and now go ahead and do it. Just by changing that position of the glenohumeral and the scapular thoracic joint, that might relieve his symptoms too. So all just little things that we're looking at. And we're going to have him spin around, work internal rotation for the subscap right there. Perfect. So those are two cuff exercises that we like. Okay, and then come on over here, Joe. Another one that I like for the cuff is the patient's going to lay on his left side. And we're going to stay with the cuff here. If you want to come around here, we're going to go sideline external rotation. So he's right here, elbows pinned, and he's rotating up to hit that posterior cuff, or infraspinatus teres minor there. That's another one. Then I might have him roll onto his stomach and do what I call a prone I and a prone T. So you're going to lay at the edge with that arm hanging down. Straight arm, the I, he's coming straight back. And here we're cueing shoulder blade, rhomboids, lower trap, big pinch there. We're getting some infraspinatus on the backside of that shoulder. So that's our prone I. We can never forget the shoulder blade complex when we're treating shoulders. This is usually where the problem actually started. And I'm going to have him do a T. So out to the side, big shoulder blade pinch is my cue. We're getting infraspinatus, all the rhomboids, a little bit of lower trap, upper trap, middle trap as well. And this whole time I'm asking, does it hurt? You know, if something like this is hurting, we're going to have to tweak it a little bit, or maybe just eliminate it for now. You can come on up. That would kind of be the day one treatment. I'm going to send him home with that. Probably see him back in just under a week and take a look at where we're at. Good.